putting a target of this 90% of patients with tuberculosis to receive high-quality diagnosis and treatment within the next 5 years. Tuberculosis every year, almost every year, more than 10 million people are affected with tuberculosis, and nearly 10% of them are children. However, the number of reported cases in children is less than 50% of the estimated cases. So there is a lot of gap in the care, the diagnosis and care of children with tuberculosis, so that we need to work hard to improve this gap for the ending TB strategy. The early recognition and detection or diagnosis of tuberculosis, as well as drug resistance, is important to achieve this purpose. The problem is more worse when it comes to children, because there are a lot of challenges in the diagnosis of children, and all the current diagnostic options, including the culture and sensitive test, do have tuberculosis patient is strong sampling of tuberculosis, and children with sphenic malnutrition, child infection, and other chronic diseases. It's really not possible to exclude tuberculosis children, even with culture and similar investigations. So this high index of suspicion is the clinical history, physical examination, and additional investigations, and of course, I'll point tuberculosis treatment children. So the other one that the other diagnostic method that is widely being implemented and expanding currently is the molecular diagnostics, which are approved or recommended by WHO as first-line investigation. Are the molecular tests, including the use of gene expert and related nucleic acid amplification tests, and even currently there is also introduction of the next generation sequencing. Some of the pediatric specimens for microbiological confirmation or diagnosis of tuberculosis are depicted here, as you can see, and you can see all of them do have a reasonable sensitivity for excellent specificity, but still, compared to what we would like to achieve, there is a significant discrepancy between our target and what we can or we have achieved. The expert MTB RAFE diagnosis, which was endorsed for the any specimen in all age group, including children, and more recently, the expert Ultra is as a new generation of expert MTB RAFE is released recently. It's approved by WHO, and there is a new additional category which is reported as trace. It will tell you whether there is resistance, recombinant resistance. You have to take another sample or use another method, but in children it is taken as a confirmed tuberculosis, and also in HIV infected and other immunocompromised patients. If you have alpha trace result, then it is taken as confirmed tuberculosis, and it is superior to expert MTB children. It is endorsed by WHO for almost most of the specimens, including gastric aspirate and even stool, even if it is less density from stool than gastric aspirate. It can be used in all comorbidities, including HIV infection, malnutrition. Of course, it is currently the preferred initial diagnostics test. The TrueNAT MTB and TrueNAT MTB RIF are attractive because they can be used in more peripheral settings because they are portable. They can be driven by battery and they are chip-based micro PCR tests. However, they are not available in our setting. The TB lamp is an important replacement for microscopy with very good sensitivity, which is comparable as expert, but this is not applicable in children. The other is antigen-based diagnostics in children and adults with HIV infection is the urine lateral flow lamp, which is recommended by WHO. It is strongly recommended for inpatient cases with severe disease, but even in OPD cases, it is associated with improved diagnostics in HIV patients. The moderate and high complex nucleic acid amplification tests are widely available currently and are important to detect the tuberculous organism as well as rifampicin in the NH register. The high complex one is also important to diagnose pyrazinamide resistance. And extra tuberculosis also can be diagnosed without culture using the low complex NAT and line probe assay. Both first line and second line probe assays are also available and they facilitate the diagnosis of MDR tuberculosis currently. However, it is not recommended to use serodiagnostic tests by our current practice. There are novel specimens, and a combination of specimens is found to improve the sensitivity of tuberculosis diagnosis. A few years ago, stool specimen was approved for expert and expert ultra, and the yield is nearly comparable to the rest of the samples. It is still lower than gastric acid and the sputum, but acceptable with a sensitivity of around 53 to 55%. And also repeated sampling, for example, from nasopharyngeal aspirate, if we take 2 nasopharyngeal aspirates, we can have a higher sensitivity compared to a single aspirate, or we can also combine different specimens, like 1 nasopharyngeal aspirate with 1 stool sample, for example, yielded 71% sensitivity compared to culture. So we can use this combination of specimens or repeat of specimens, like repeat gastric aspirate or repeat nasopharyngeal aspirate, or a combination of stool sample with respiratory sample, which may improve our diagnostic yield by nearly 33%. The other important point in children that is of course commonly practiced by the pediatricians is the use of presumptive pulmonary tuberculosis diagnosis, and that is recently recommended to be used as an integrated treatment decision algorithm by WHO guideline development group. And there are 2 algorithms. Algorithm 1 is, or algorithm A is in settings where there is chest X-ray, and the second one is algorithm B in settings where there is no chest X-ray. So this is purely the use of a combination of clinical as well as laboratory imaging methods to diagnose tuberculosis. So with this with this algorithm, in settings where the first one is for chest X-ray available settings, this guideline is for children less than 10 years. Children more than 10 years are better diagnosed based on laboratory tests whenever possible. So this algorithm is for children less than 10 years. So we evaluate whether there are danger signs, and we stabilize them if there is one. And for children with HIV and severe malnutrition, as well as younger children less than 2 years, we directly should test for tuberculosis using molecular tests like expert or ultra, and in HIV infection, of course, we use also urine. And if we identify the organism, tuberculosis, mycobacterium tuberculosis, we initiate treatment. Otherwise, if the child is older and not HIV infected or not associated, not severe reminders, then we treat the acute phase, acute possibilities like pneumonia also, and see the response. If the symptoms persist for more than 1 to 2 weeks, we then proceed to the test. And if the organism is identified, then we treat. Otherwise, if there is no organism identified, we decide based on the contact list. A child who has no response to pneumonia treatment or has other persistent TB symptoms and has a contact history, then we score. We go directly to treatment. If there is no contact history, then we proceed to scoring of signs and symptoms in chest X-ray. So we score signs and symptoms separately, and also chest X-ray scoring separately. And combining the two scores, if we have a sum more than 10, it is a presumptive diagnosis of tuberculosis, and treatment should be started. If the score is less than 10, we should re-evaluate the child in 1 to 2 weeks and rescore the clinical score and chest X-ray score again and decide accordingly. In settings where there is no chest X-ray, what we should do is the others are just the same. We score only the signs and symptoms, and they are given a higher score here. And any score that is greater than 10 warrants initiation of antibiotic. An important thing is chest X-ray in pediatric tuberculosis for diagnosis. As you can see, there is a very poor sensitivity, even if specificity is very good. And there are different abnormalities that could suggest tuberculosis. For example, primary tuberculosis in children typically will have hilar lymphadenopathy with possible collapse consolidation. Otherwise, miliary and cavitating lesions are also important findings. When we see the future of pediatric TB diagnosis, there is a very good progress in the pathogen-based assays. For example, there are improved assays for the LAM. For example, recently the Fuji LAM and ultrasensitive LAM are introduced, and they have a much better performance than the previous LAM, which was from Ale. And molecular diagnostic assays are also significantly progressing better with available point of care nucleic acid amplification tests, next generation sequencing, and even circulating free DNA. Novel specimens are possible already. The stool is already approved. Oral swabs have been tested, but the rate is actually low, less than 30%. Bioaerosol sampling, where, for example, from just face mask, were tested in adults, and they were found to be very good in detecting subclinical disease even, but there are limited data in children. Volatile organic compounds are interesting in respiratory disease, including asthma, and also in tuberculosis. We are able to identify the signatures that were able to distinguish children with tuberculosis. And African rats were actually trained to sniff breezes from pediatric infected sputum, and they were significantly improving the detection level of tuberculosis. They actually reported more than 40% improvement of detection. Electronic nose devices are also being tested, and there are promising results. The other current evaluation in research is host-based assays, and there are a lot of candidates in this arena, so there are researches going on. Samples for host-based assays includes saliva, adult salivary cytokines were found to predict positive tuberculosis screening, but there are limited data in children. But you can imagine if we are able to diagnose tuberculosis from hospital, that will be very non-invasive and very convenient, and probably it is not far from clinical introduction. The other is the role of omics in TB diagnostics. We are already in good progress, especially in adults, and also in children. There are some metabolites that could that have been able to help with to distinguish TB from other diseases with a reasonably high diagnostic accuracy. Digital health is what we are in currently. So computer-aided diagnosis using AI-based chest X-ray reading and AI-based point-of-care ultrasound. Both of them have been promising in the evaluation of patients and improving the diagnosis of tuberculosis and other respiratory diseases like pneumonia in children. So in summary, pediatric TB is treatable and of course preventable. So timely and accurate detection will increase the chance of better treatment. It will avoid complications and will help with global tuberculosis control. Even if pediatric TB is a diagnostic challenge, there have been a lot of progress, especially in the last few years. Portable point-of-care molecular tests are being decentralized. A lot of remote places are now having these experts and other molecular diagnostic tests available, and they are non-respiratory, easy to collect samples. For example, already stool is introduced, even if there are still some limitations with that. And in the future, probably we'll have this inhalation of saliva samples which are very convenient and non-invasive in children. And clinical algorithms are sensitive and very important. Of course, they will over-diagnose TB, but it is better to accept more over-diagnosis than missing a child with tuberculosis and accepting a death of a child from tuberculosis. And finally, in searching for future pediatric diagnostic tests, it's important to include those children in the initial evaluation of those tests. Thank you very much.